Hello, everyone. Sorry if I cut your break short. I'm Dan Lee. I do pediatric critical care in the burn unit, and I do adult and pediatric anesthesia. And I'm going to talk about kids and burns and hopefully just give you a good gestalt for the differences that are important. And maybe most importantly at the end, I'll show some pictures of different things that are suspicious for abuse that are worth reporting, and we'll have a little bit of a conversation about that. So the goals of the presentation, obviously to understand how the child is different, there's everything from development to their metabolic rate. There's a lot of differences between kids and adults that are important. We'll talk about what things are unique when you're assessing kids with burns, and then also the child abuse, as I said. I completely forgot I had that slide. So annually, about 25% of all burn injuries occur in kids who are less than 15 years old. Unintentional fire or burn injuries is actually the 5th leading cause of death in children age 1 to 4. For 2015 is the last year the CDC has data for. It's the 3rd leading cause of death for kids age 5 to 9. Kids under 5 years old are actually 2.4 times more likely than the general population to have injuries that require some kind of emergency medical treatment. And in kids under 3, scald burns are the most common. They are often associated with child abuse. That's not really the right. Scald burns are prevalent in child abuse is a better way to put that. Flame burns are most common in kids who are older. This is actually a picture from Afghanistan, but we've taken care of kids in Mexico who were playing this game where you light a soccer ball on fire with gasoline and you kick it around, and eventually clothing can light on fire and then you have a bad burn. So this is one of the reasons kids older than 3, especially boys, run into problems with burns. So kids have a really big body surface area compared to how many kilos they weigh, so they're a lot more susceptible to things like heat loss and insensible losses compared to adults. And by the time kids are about 15 years old, they've kind of gotten to the adult BSA to weight ratio. Kids get cold very easily. I mean, burns in general, I'm sure you've already had the talk or you're going to have the talk about how cold burns can get and how fast. Kids even more so. They have a small muscle mass. Infants don't even really shiver well. They have trouble regulating their body temperature. So highly susceptible to the development of hypothermia. The other thing about kids, though, is their skin is very thin. They can very quickly burn. In a situation where an adult would not get a severe burn, probably wouldn't even have to go to the hospital. Burns that can appear partial thickness in a child, maybe on the first day when you look at the burn, can end up kind of developing and maturing into a full thickness burn over the next few days. So that follow-up is very important, especially with kids. When we have a burn that looks like it could be deep, but we're not quite sure, it can take 3 to 5 days to figure that out. So I think to give you an idea of the difference between how sensitive kids and adults are to different temperatures of liquids, if you look at the very top, if you have anything that's about 160 degrees, which really qualifies as Starbucks coffee, right? You can get an almost instantaneous full thickness burn. That's why McDonald's paid out $1 million to somebody who scalded her lap. So 160 degrees is just horrible to have. And actually, to put that in perspective, there are some apartment buildings and some larger institutions that will have hot water heaters that can approach that temperature so that you can be economical having a fairly small volume of water that you're heating and then distribute that around to a larger area. So it's especially important to pay attention to water heater temperatures anywhere, especially where there's a child. But we've seen burns in people who got in a shower, turned the shower on. Like I think I've seen one. It was someone in a hotel. They turned it on, and it was basically 160 degree water. It hit them. They jumped out of the shower right away, and they had a full thickness burn. So even with adults, this can happen, but it's very easy to happen in a child. When you get down to 130, 140 degrees, you see there's about a 3-fold difference between how much time an adult could be exposed to a certain temperature versus a child. And when you get down to about 110 degrees, you can tolerate the temperature for a time. It's just uncomfortable. Hot water heaters, I personally like about 120 degrees and no higher. Some people will talk about maybe 125, but that's about the highest I've ever seen recommended. All right, so the initial evaluation for a child, there's a couple different things maybe than adults. Their past medical history is important. If they take any medications is important. And it's probably worth reminding you about this because, you know, if you see a child who looks pretty healthy, you might forget to ask, do they have other medical problems? Do they take medicines at home? For all you know, their shirt is hiding a midline sternotomy scar and they're on like 5 different cardiac meds and they've had 5 cardiac surgeries. So, and when you look at the prevalence of abuse in different populations, kids who have special needs, kids who've had a lot of medical problems are a little more prone to be subject to abuse just because of the difficulties around that kind of lifestyle for the whole family. So the other thing is the immunization status in kids, it could go either way. Most kids are going to be closer to their last tetanus shot than most adults. So you give a lot of tetanus boosters to adults who've got a burn in a dirty environment, whereas most kids, you can just find out that they're up to date and you're fine. However, you know, up here in La Jolla, for instance, there are plenty of kids who've never had an immunization, and we've been fairly successful. I mean, I can't think of the last person who turned us down, at least for a tetanus shot in a burn where it was fairly obvious they were going to be at risk. And then allergy is obviously important to ask too. It's just it's hard when you're looking at a healthy kid to remember that they may have had a really significant past medical history. The events leading to the injury are very important. Part of the reason is you need to figure out, do you need to do a full trauma evacuation? Do you need to get them to a trauma hospital right away? Did they sustain some other injuries besides the fire? One of the things that you need to look out for is if the burn it was caused by some kind of non-accidental trauma, that also the kid might have been beat up. They might have other injuries. I've been in situations, I did a transport from Tri-City once with a child who we were seeing just for seizures. It was new onset seizures, that's all it was. They said she had a fever or something, and people were thinking maybe it's febrile seizures. No one was that excited. And when we went to see the kid, by then the kid was comatose, and it turns out, to make a long story short, this child had multiple rib fractures, had been being beaten probably for months, and had subdural hematomas, and was really in bad shape. Where the history didn't really tell us any of that. So the patient's developmental milestones are important to know too. If you get a story that, you know, a child crawled over a heating grate and the child doesn't even know how to crawl yet, and that was supposed to explain a burn on their hand, you realize the story isn't quite fitting with what the child can even do. The burn depth, I mean, it can be helpful when you get your history to figure out what they got burned by, right? I mean, partly because you want to make sure it's not a chemical and that you've got to somehow deal with that in a different way than you deal with some kind of a temperature burn. But if it's a hot boiling oil burn, it's going to be different from just a boiling water burn and very different from a hot water heater that was 120 degrees. It gives you an idea early on what the depth might be. If you're seeing somebody in a clinic and the story is, you know, this was hot boiling oil that got on them, you're going to send them to the burn center right away. You're not going to wrap them up on a Friday night and say, go to the burn center on Monday. The body surface area involved is important, but also the mechanism, what happened. You know, if it's a house fire, you've got to think about carbon monoxide poisoning, which can be a real emergency. Is the airway at risk? Do they have burns over their neck or their face? Do they have circumferential burns? I think Dr. Lee is going to talk in the next talk about escharotomies. But what you're looking for are reasons for them to get to care very quickly and reasons maybe to do some other blood tests like a carbon monoxide level. So I actually forgot to mention this last point. Burns over about 20% total body surface area. After an hour or two, if you're adequately resuscitating them, they can get really, really edematous and even have some issues with their airway. Especially kids can have issues with their airway just because they've gotten so swollen. So these really big burns, if you're moonlighting in El Centro and there's a kid you're going to transport to us, but the winds are too high for a helicopter to come over the pass, and they're going to come on an ambulance, and it's going to take them a couple hours to get here, and they've got 30-40% burn. Actually, that's the time when maybe you do call the ED and have them intubated early. So there is a rule of nines for body surface area burn in kids. It's different than adults. I have to say I'm a little bit lazy, so I have another way to do this besides the rule of nines, but this does exist and it's in your handout. You do not include first degree burns. So very superficial burns don't count as the body surface area burned when you're doing your calculations for fluids and things like that. Gradually until the teen years, this rule of nines is changing, of course. But it turns out if you just look at a child's palm, it's going to be about 1%. So every time I see a new kid with a burn, I look at their palm and then I just kind of go over their body and roughly figure out what the burn is. And it's usually pretty accurate, I think. It's certainly always easy. But I think it's a very accurate way to get an idea of your TBSA burn. So the immediate resuscitation is going to be very similar in adults and kids. One of the things with kids is I guess you have to be a little more suspicious of chemical burns. Every once in a while someone comes in, you don't know exactly what happened. Everyone's assuming that it was some kind of hot water. But because you're not getting that kind of history you might get with an adult, be just a little more suspicious about it. Think about the possibility of a chemical burn. So you do want to remove clothing. You'll examine the entire body surface. Part of stopping the burning process, if it's a chemical burn, is two things really. I mean, you wash off whatever chemical is on the skin, but also you can call a poison control center and find out, is there significant absorption? Is there something I can put on it that would neutralize it, and so on. So, if you know what the substance is, you might as well call a poison control center. They tend to be pretty smart people, and they have good computers too. And then really you just cover the burns with dry, clean linen, keep the patient warm, and transfer. So it turns out, I guess it's obvious, but it's not obvious, that one of the most important things we do in the early resuscitation of a burn, really the important thing we do, is resuscitate them. They're losing a ton of fluids because they've lost the protective barrier of their skin, and we need to replace those fluids. And it turns out this is really super important because before we had regional burn centers, and they looked at what was the main cause of morbidity and mortality early in a burn resuscitation, it was renal failure. And if you go to a burn center, you're much less likely to have renal failure than if you're cared for in a place that just doesn't routinely take care of burns. So you don't want to delay that resuscitation. You don't want to underestimate your needs. What we really do is we just follow the urine output. You'll do a TBSA calculation and you'll figure out how many fluids you want to give in the first 8 hours. But in the end, you're going to watch their urine output and you're going to keep them at 1 or 2 cc's per kilo per hour. If they have injury that might come along with some myoglobinuria, for instance, a large electrical burn, you're definitely going to keep at the upper end of that urine output to try to save the kidneys too. In the end, if you're not sure, you can always call a burn center and talk about what you're thinking about doing. I think lactates are also incredibly valuable to follow the pH as you resuscitate someone, to follow the lactate. As you catch up, the lactate should be improving. There are soft things like sensorium and peripheral circulation and so on, but I think really a lactate and a urine output following some basic labs gets you a lot of information. So I won't spend a ton of time on this. It's in the handout. Most of you probably already knew this coming into it. You start the fluid resuscitation right away. If you can get large bore access, that's great. If you can't, if you just get one small IV in a kid, you can give a decent amount of fluid in a small IV, as it turns out. So I guess in the end, don't be greedy. If you have trouble with your first IV or two and you're trying really big IVs, just use a small IV. Having something is better than nothing. The other thing is, the first couple hours, a lot of kids will drink a lot. They're not feeling too bad yet. You give them some morphine, they're feeling better. So if you didn't give them too much morphine and they're awake and thirsty, go ahead and let them drink. Don't let them drink like a milkshake or a big cup of milk or something in case we want to do an anesthetic right away. But they can have clear fluids and hopefully catch themselves up even better than your IV might. All right. In kids, what is different than adults is their maintenance fluids needs are very different. In the first 10 kilos, you give 4 cc's per kilo. So a 10-kilo kid is getting 40 cc's an hour. You give 2 cc's per kilo for the next 10, so a 20-kilo kid is getting 60 cc's an hour. And that's just for their regular maintenance if they're NPO. And then it just goes up by 1 for every kilo after that. The resuscitation is going to be separate. That's the 4 cc's per kilo per body surface area. And in the first 8 hours post-burn, you usually try to give about half that, and then you follow the urine output and make adjustments. Don't forget to monitor electrolytes. We're giving a lot of fluid, and the fluids we're giving aren't perfect fluids that exactly mimic what your body wants to see. So in your handout is an example of how you would do a calculation for a child with a 20% total body surface area burn who weighs 23 kilos. This last point is the main point I wanted to make, that lactated ringers is hypotonic, as sodium is 130. Kids are very prone to get hyponatremic because of the high volume of fluids we give them. There's even been situations just in the general pediatric population getting maintenance IV fluids back in the days when we frequently gave quarter normal saline or half normal saline, kids having seizures and even dying from hyponatremia just with fluid replacement that they're getting because they're NPO for some reason in the hospital. So just be cognizant of the fact that kids' electrolytes can get out of whack even quicker than adults, and sodium's especially important. Obviously, potassium's important. Calcium is another favorite of mine because when it gets low, you have more blood pressure issues, pressors don't work as well, and so on. So pay attention to electrolytes. So you've done the immediate resuscitation as far as stopping the burning process, and you've cleaned them off, and you're thinking about transporting. You do need to think about the airway before you transport, though, especially if it's a longer transport. So endotracheal intubation might be indicated. You want to be careful. Like if you have a child with a perfectly good airway and you don't have anybody around who really takes care of pediatric airways ever, that's not when you want to jump into intubating them unless it's really completely necessary. And I have a solution for that if it ends up being completely necessary. So the Children's Hospital Emergency Transport Team, they will come to you. They can even come with a doc, depending on the type of transport they're doing. But even without a doc, they've got RTs who intubate really well. They've got nurses who will put in central lines. So I'm pretty sure the nurses put in central lines. They certainly can put in a bunch of IVs. You can resuscitate anybody with an IV. You don't need a central line. But they will come and manage the airway for you. So if you're doing that transport from El Centro or something, you might actually, before maybe they get in a helicopter to come over, want the CHET team to be the people coming over on the helicopter. They can look at the kid, they can decide if they need to intubate, and then they can do that. So I did want to, I'm just going to say, I think I have 2 slides about the pediatric airway and burns. I just wanted you to have a couple things in the back of your mind if you have to help a kid out a little with their breathing early on. It turns out most kids, like I said, first hour or 2, they can manage their airway pretty well before they swell up too much and so on. The exception would be children, kids who've got actual physical burns to the airway or circumferential around the neck or something. Common reasons for intubation are going to be deep facial or neck burns. They can swell pretty quickly and they'll swell a little faster than usual. Circumferential neck burns, eventually that's going to be a big issue just as far as compressing the airway and can make it very difficult to intubate just even an hour later. The large burns I talked about, more than 20% or so, there's going to be significant swelling with resuscitation over the first hour or 2 usually. You can get really swollen. It's surprising. Bronchial injury from smoke inhalation. So depending on what kind of fire you're in, if you're in a chemical fire, there can be some really noxious things in there, worse than just regular smoke, that can almost immediately cause a chemical injury to the tracheobronchial tree. And very quickly you can get swelling, you can have a lot of secretions, and have a lot of difficulty managing your airway fast. Oropharyngeal edema and blistering. Now the lower figure there is actually what you're supposed to be looking at is vocal cords and an epiglottis, and all you can see is a heck of a lot of swelling, and this essentially is epiglottitis. But it turns out this was a grandfather was taking care of a kid, made hot tea for him, accidentally heated it up for 5 minutes or something instead of a minute. The kid got the tea, drank it, and it got all the way down to his vocal cords before he realized how hot it was and coughed it up. And so he had a horrible case of epiglottitis, which is a life-threatening issue. So you can have direct burns to the airway, which are important. You can have the same kind of thing happen with chemical burns. And then altered mental status and inability to protect airway. If you're in a house fire, eventually you will become unconscious, you will have very high carbon monoxide levels, and eventually that will kill you. If the firefighters get you out of the house in time, you've got a shot. But at that point, you can't protect your airway, you're completely out of it, your GCS is 3, right? So we often will end up intubating people purely because they're unconscious and they can't protect their airway. If you decide, so you look at your kid, you realize somehow you need to manage the airway more than you are, then I would recommend it, if you're at a hospital, talk to your emergency room. If you're not at a hospital, maybe call the Children's Hospital Emergency Transport Team, the CHET team, have them come so that they can help you out and evaluate the airway. But you want to get people together who are used to taking care of kids. It tends to be that emergency rooms are the most common place where you're going to see that in most hospitals. This is probably my only other airway slide. I just wanted to remind you about a couple things. Let's say you have a kid come in, a kid's rushed into your clinic or rushed into an emergency room or something, and they've got a big burn, and they're not super responsive, and they're obstructing a lot, and their oxygen saturation isn't great. It's not like you necessarily have to intubate them right away, but what you probably have to do is overcome some of the anatomical problems that often, especially little kids will have. So babies and toddlers still have a huge occiput. So if you have a kid who's just kind of laying there and he's very flexed because his occiput's so big, that might be the only reason he's obstructing. And if you just kind of open up his airway a little bit and lean him back, try to get him in a position, we call it a sniff position. It's like where it almost looks like they're trying to smell a flower. But if you get them in a better position, maybe their airway opens up and they breathe, and then you have time for the emergency room to come or for the CHET team to come. Maybe you put a little mask on them. As kids get older, sometimes it's helpful actually to have a small pillow or a rolled up blanket under their head. Again, you're just trying to get a good anatomically normal position of the airway to keep it open. I lied, I have one last slide about airways in kids. So one of the reasons we have such a problem with kids who get a big resuscitation, who've got a 30% burn, is that a little bit of swelling goes a long way when you have a small airway. There's a physical law, Poiseuille's law, that shows that if the diameter of a tube, if you decrease the diameter of the tube, it has an effect on flow through that tube to the 4th power. It's a tremendous effect. And kids are already starting out with such a small airway. It's just small millimeter changes in the airway size can make them start to have a lot of air hunger and not be able to adequately ventilate. Kids are not just little adults. Their larynx is located a little more cephalad. They can be a little more difficult to intubate. So if you have an emergency room doc who intubates adults all the time and not kids, don't feel totally confident that it's going to be just as easy for them to intubate a kid. The narrowest point is the cricoid, not the vocal cords. And again, that's an area that can swell up fairly early in a resuscitation and make it difficult for a child to breathe. And the larger tongue in the kids can be an issue, especially as they become a little obtunded, maybe they get some morphine. It's a little easier for them to obstruct. And truth in advertising, I did emergency medicine for a few years for kids, and I completely respect what ED docs have to do. I don't actually know if any ED docs are here, but what I meant saying it's not going to be as easy for them to intubate a kid as an adult. It's the same for anesthesiologists. It's the same for everybody who has to intubate children compared to adults. That children sometimes can be more challenging. I just didn't want anyone to think I was dissing ED docs. Some of my best friends are ED docs. So I just said kids aren't little adults. And it turns out you can sometimes pretend kids are little adults, and it can help you with some of your calculations, being comfortable figuring out what drugs you're going to give. So you may be in a situation that you didn't expect to find yourself in, where you've got a kid who needs a little bit of resuscitation, maybe needs some meds. And you decide you want to support a kid with some epinephrine and you can't quite remember the dose. Or you calculated the dose and then you're not really sure if you calculated it right. So this is a way you can double check your calculations even. So what I do is I just figure every adult is 100 kilograms, and if I have a kid who's 10 kilograms, they're 1/10 of an adult, and they're going to get 1/10 of a dose I'd give to an adult. So an example would be, there's a 10 cc epinephrine syringe that we use for cardiac arrest, And a 100-kilo adult gets all 10 cc's, and that 10-kilo kid is going to get 1 cc. So if you calculate out how much epi you want to give a kid, and it's 100 mics and it's 1 cc, and you're nervous about it and thinking, God, did I do that right? You can use this just to make sure, oh yeah, that totally makes sense. He's about 1/10 of an adult. And if you don't have a weight, you can just look at the kid and know, like, does that look like 1/5 of an adult? Does that look like 1/2 of an adult? And you'll be in the ballpark with all your meds. The endotracheal tube diameter is like their little finger. So if you look at a kid's little finger, that should be roughly the size of the endotracheal tube you can use. I always would use a cuffed endotracheal tube. So if you guess too small and there's a big air leak and you can't adequately expand the lungs, you just blow the cuff up and then you've got a good seal and you can ventilate the lungs. And the depth is just 3 times whatever the size tube is. So if their little finger got you a 5.0 tube, then 5 times 3 is 15, and it'll be about 15 centimeters at the lip. For neonates, I don't know how important this is, but I think actually it probably is very important. Any of us could end up being in a situation where a baby gets delivered, and we're a healthcare professional, and we're supposed to somehow be able to help out. And maybe EMTs come, and they've got airways and things, and they're going to even intubate a kid. So it's worthwhile knowing how deep a tube should be. I've seen, I know of, I wasn't involved in this and I didn't see it, and I don't know what hospital it was at, but I do know of a time when a child was born, wasn't breathing very well, got intubated, and then arrested. And during the arrest, they gave epinephrine, they ventilated really aggressively, they couldn't get the kid back. Someone else was called for help. A pediatric anesthesiologist showed up and noticed that the endotracheal tube was 14 centimeters at the lip in a neonate. And I can tell you the deepest I've ever had a tube in a neonate is about 10 centimeters. So the pediatric anesthesiologist pulled the tube out 4 centimeters, way out of probably the distal right lung. And then the child was ventilating and oxygenating, and the heart came back, but the child was brain dead by then. So tube depth actually can be super important, and just being a bystander somewhere when someone's having trouble resuscitating a child, you can help by just making sure the tube isn't main stemmed. And the smaller you are, the more susceptible you are to a big problem with the main stem intubation. If you gave me a main stem intubation, my SATs would be down a little bit, but I'd be fine. For babies, it's not the same. So there is a way to remember. Babies are usually 1, 2, 3, or maybe 4 kilos. The 4 kilos is really tough. And so if you figure 1, 2, 3, or 4 kilos, then 7, 8, 9, 10 centimeters. So 1, 2, 3, 4, 7, 8, 9, 10 centimeters at the lip will get you roughly to where your endotracheal tube should be. So part of the reason I wanted to go through this is it's all kind of complicated, and if you don't do it all the time, it doesn't make sense to think, oh, I was at a talk 2 years ago and I think they said 1, 2, 3, 4, but I don't remember the last part. So it turns out there's a Broslow system that hopefully most of you know about. It's a fantastic system. It's this color-coded measuring tape. You lay the kid out on the tape. They get to a certain color, and that color it corresponds to a drawer in a cart, and you pull the cart out, you pull the drawer out, and you've got everything you need. And you also have a rough weight. So wherever the heel comes to on the kid, it'll actually give you a rough weight of the child. So there's also color-coded drug dosing cards. The old dosing cards were a little bit stupid because they only had a concentration, I think, for epinephrine, but there were some things like calcium. It would say you give, whatever cc's per kilo or something. It was just weird because they didn't have concentrations and so on. But there's new cards from 2017 that I think are excellent that tell you everything from, drug doses for your kid to how many joules you use if you're going to defibrillate them. So it's a very, very useful tool. All right, the last thing I'm going to talk about is child abuse, and I'm going to show you some pictures in the next few slides. Oh, there we go. So I'll show you some pictures just to try to put it in your head that if you see something suspicious, you might as well just call. And I put here that these are things you already know. But it can be hard. You meet a really nice set of parents and a cute kid, and then you see something that's suspicious to you, and you think, oh my God, am I going to have to report them to CPS? In the end, yeah, you just should do it. And you tell them we have to report We have to report anything we're suspicious of, and a lot of times it ends up being nothing. But we'd feel awful if we ended up, for instance, if their child was with a caregiver, and maybe the caregiver was doing something. So it's protecting the child. It potentially even is protecting the family. So if you're a little bit suspicious, just report it. If the injury pattern isn't consistent with the history you get, that's enough. That's enough that you should report it, because somebody's hiding something. Somebody is saying something that just doesn't jive. What? Oh. And if the lines of demarcation between normal and burned skin, and I'll show you a picture of this later, are really straight, almost like a glove pattern, like maybe somebody held somebody down in some hot liquid or something, it doesn't quite jive with what you'd expect to see if a child accidentally got burned. Again, just report it. It may be that they'll come to the burn center, CPS is already involved, maybe we'll look at it and say, you know what, that actually makes sense with what the parent said. It's not a big deal. CPS will talk to them, they'll find out there have been no other referrals, we'll tell them that it looks okay to us, that's fine. If there's any delay in seeking medical attention, I think you should always call CPS, because you do have to wonder. Sometimes it's just that the parent was so drunk they didn't want to make the referral right away till they sobered up, but that is an issue where maybe CPS should look at the family, especially if them being drunk was part of why the injury happened. Changing stories, contradictory stories. Think about the developmental milestones. I'm going to show you a picture of a situation where a child could not possibly have done what someone said they did to get a severe burn. And then if the details aren't really concordant. So what CPS will do, the sheriff's department will go out and sometimes take pictures at a home. So maybe you get this detailed description of how a shower was on, and that's how the kid got this really weird burn, and it dripped on them or something. And then the sheriff's office goes and they don't even have a shower. So or they take a picture of it and it's just a bathtub and there's no shower head or anything. So potentially you're going to see something where the story doesn't make sense with an investigation, and that's another red flag for basically us trying to get more information and figure out what really happened. So the photos in the next slides, many of them are not burns. They're useful to keep in mind because you may see them along with a burn. And some of these injuries should lead to a full trauma activation. So this is this is a kid who fell off a couch, and it's a toddler, it's a femur fracture. That's really hard to do. Unless someone really big is falling on you with a boot on, you're not going to get that fracture falling off a couch. Or maybe you have osteogenesis imperfecta. So it turns out, this is a very sad story. So this is a kid, I consulted at a hospital once because of this problem they had, and they were trying to figure out how to have this not happen again and so on. And what happened is this kid came through, he saw orthopedic surgeons, he saw nurses, probably never saw a social worker, and got their bone fixed and went home. And nobody asked the question, how did this kid break his femur? And a month later, he ended up dead with non-accidental trauma with shaken baby syndrome. So the way I would think about it when you're thinking to yourself, God, do I really want to report this to CPS, is that you may avoid something like this. And it's up to CPS to sort out if there's something wrong or not. You need to take every opportunity possible to help a kid out who's in this kind of situation. This is one where you may find rib fractures on a chest x-ray you're taking because a kid's got new onset asthma or something. And this actually is a child who's got rib fractures in all different stages of healing. So this is a no-brainer. I mean, this kid's getting beat up, and this didn't just happen once. This is another one where there's no history, but there's an injury. So a pediatrician saw this kid at a regular well child check and saw, wow, she's not really using her hand much, and she's got this big bruise on her hand, and she's got fractures like a boxer would have after a horrible fight, and there's no history. Nobody knows how this happened. Something's going on there. You need to get CPS involved. You need to figure out who did this, how it happened, because this would be the kind of event that would be witnessed and known about. And the fact that she's not using her hand at all, and they didn't even bring them in for that, is another warning sign. Healing fractures with no history. So you have a kid who's got a sprained wrist or something, you get an x-ray, you realize there's a 2-week-old fracture there, and there's no history for it, you don't know why it happened. That's a CPS report to try to figure out what did happen. Healing fractures with no history. This was an incidental finding in a kid who got an abdominal film. This is why you always send your films on to a radiologist to actually read the film, because we might look at it and say, oh, it's a nonspecific bowel gas pattern, and the radiologist looks at it and says, well, he's got a rib fracture. This is a child with cerebral palsy. So this actually, there's a correlate to this in adults with elder abuse. So if you've got someone who can't really take care of themselves or can't give you a history, and they've got an unexplained fracture, like this was a wheelchair-bound patient with cerebral palsy, no history of anything bad ever happening, who's got a horrible fracture. And it turns out a caregiver was beating this person. So again, things that don't have a history, don't have a good explanation, just go ahead and report it. Same thing goes for anyone who's in any kind of long-term care. This is a crazy story. I've only got a couple minutes, so I'm trying to think if I can say this really fast. Basically, this kid's got a bad neck fracture. If you look anterior to where you're seeing the bones of the spine, there's this huge wide area. That's all blood. That's blood from a fracture that this kid had like a week before. This kid's walking around, which is amazing, but this kid needs a surgery bad. If he even gets hit hard or falls down, he's going to be like a C2 quadriplegic. And it turns out this kid had been beaten up. He got a neck fracture. He had belly injuries. He had a lot of other stuff going on. He initially was sent to foster care. He came back in with continued neck pain, and he had this. So I guess this is another reason to take a lot of x-rays when you see kids. So when we see kids in the burn unit, and commonly when any child gets a non-accidental trauma evaluation, you do a whole series of x-rays. Somehow it's called a skeletal series, because you are looking for hidden fractures. This child somehow didn't get a neck x-ray until a week after all this happened. All right, I've only got 2 more slides, maybe 3. Skin findings, unrelated to burns again. This, you can almost see like a handprint, like a slap mark. If you see something, an odd bruise, that just doesn't make any sense. The kid's not even mobile. How's he going to get into enough trouble to get bruises on his face? And when you look at it carefully, it does look like a slap. This is one, that's a spleen, and this is somebody who got punched in the stomach. What you see that's suspicious is this bruising over the liver area, right? It turns out this kid had multiple injuries, had a liver lac, had a grade 4 splenic lac, had to get a splenectomy. And it was because the kid got beaten up by a boyfriend. I'm sorry, I'm going to depress all of you guys. There's lots of great parents we see in the burn unit who take such good care of their kids and love their kids. So I do apologize for this. And then I'm going to show you bite marks from a babysitter. This is one where if you see a kid and you can't quite figure out how they got their injury, sometimes the sheriff's department will go look at it and it'll make sense. Like they'll have a weird shower, or they'll have the kind of faucet that turns hot separately from cold, and you totally could see how a kid could turn that, get a big scald. They'll measure the temperature of the water in the water heater, and it's 160 degrees. So then you realize, oh yeah, that's what happened. There's a good one. I didn't show you this picture because I was trying to show you pictures of actual non-accidental trauma, but there's one I have of a kid who got burned by a garden hose. So the garden hose was sitting outside all day, and I think it was local. It wasn't even like it was in Phoenix or something, but it was sitting out all day, and it turns out the water in that garden hose got up to about 150 degrees. And the mom turned on the garden hose, and this little toddler loved to play with the hose, and got 150-degree water all over him and got a really bad burn. And nobody believed it, and the sheriff's department went and measured it, and they're like, well, yeah, that's what happened. So it's useful to go look at things. This was a chip clip from a caregiver. This is just where a belt corresponded with an injury that was seen. So I will talk about burns a little bit. If you think about hot surfaces like curling irons and regular irons, if you get a description of a glancing blow where it fell off on the side and kind of hit their leg, but when you look at it, it looks like somebody held it on there. You at least should have a burn center look at them. Even as a burn center, we often will have child advocacy people from the community who are especially trained to look for signs of abuse. They work closely with CPS, have them look at it as well, because that doesn't really fit with a glancing blow if it looks like somebody just held something on there. And you may get a story that the iron got trapped under them and then they had to get pulled off. Then maybe that makes sense. So part of it, you're trying to get a story that makes sense for the injury. Sometimes you will see patterns of injury that don't make a lot of sense until somebody goes to the house and finds out from somebody what really happened. This is a case of a kid who is like 4 months old, not even really rolling over well yet, and the caregiver said that she had crawled over a hot grate in the house, and it turns out obviously that didn't happen. The caregiver was upset because the kid was crying and did it as a punishment. This is another one. I was talking about that kind of stocking glove pattern when you have a really clear demarcation in an area that's burned. This is the kind of thing, just go ahead and report to CPS. They'll look into it. The burn center will take a look at it and try to fit it with the history. But this kind of thing, I think, should definitely cause some further investigation. And another kind of obvious burn that's crazy. So this is actually my last slide. Since we're talking about kids, we can have a lot of impact on whether or not kids do get burned. In my first slide, I had a cup of noodle thing, and cup of noodles make me absolutely crazy. We see a ton of burns with those. It's a pretty package. People want to grab it, and it comes out, scalding hot from the microwave. So, developmental awareness is important. So again, I'm talking about kind of educating families and educating ourselves. Caregivers, other than the parents, often are very surprised where kids can get into. They never would think that a kid could reach up onto a counter where they put this hot scalding coffee until the kid does it. So it is important that once a kid is even crawling, that people are starting to really think about child-proofing a house really well, and anyone who takes care of the kid should be really cognizant of that, and especially about potential burn injuries. Children don't have really good impulse control. They may fall into a fire pit or run through a fire pit without thinking about it. Post-burn psychological and PTSD support's very important in kids and adults. Scald safety is important. People, we had a scald in a sweet 9-year-old kid. I'm totally going to depress you guys. I'm sorry, but he was a great kid. But so really sweet kid, he wanted to make his mom some soup. So he went to the microwave and used it for the first time and made scalding hot soup. And when he went to grab it, it was so hot, it scared him, and he dropped it, and he scalded himself really badly, all over his groin. I mean, it was just bad. And he did fine. He was totally fine. But access to a microwave, cooking, and things like that, it's important to educate people about. I talked about water heater temperatures. Open fire safety is really important. Coals can stay hot enough for 24 hours. I mean, we just recently had a burn. The family, they were totally with it, and they'd been camping for years, and they had poured a bunch of water on a fire to put the coals out the night before, but they didn't quite get everything, and they didn't use quite as much water as they wish they would have. And then one of their kids tripped and fell into the fire pit and got some full thickness burns from it, from some coals that the water just didn't get to. Anyway, it's important that people are aware of that. Home evacuation plans are really important. In the end, there's never a reason to go back into a house that's burning, except maybe, so if it was me and it was one of my kids, so if it's a human being in there, I'll go back to try to get them, right? I probably would do that. But don't go back in to get anything else. And what people don't realize is they might feel like, well, the fire's just in the back of the house. I'm just going to go to the front and get my computer or something. But people die in fires because of smoke inhalation, right? It's not just that they got a bad burn, and it doesn't take a lot maybe to get a little disoriented and confused, and it's smoky and you can't get out, and then your carbon monoxide level's 40, and you never wake up. So it's important that everyone in the family knows that. If you've got people on a second floor, figure out how you're going to get them out. And I think that's all I have. And I do, I apologize. I give kind of a depressing talk at the end, but that's a really super cute kid there, and the water's not cold at all, not hot at all. The stove's not even on. So any questions?